Good afternoon, everyone. We're delighted that you could join us today. The title of today's webinar is Shared Decision Making for Chronic Conditions and Long-Term Care Planning. The webinar is sponsored by the Agency for Healthcare Research and Quality. My name is Arlene Bierman, and it is my pleasure to serve as a moderator for today's presentations. I am the Director of the Center for Evidence and Practice Improvement at AHRQ, and CEPI is tasked with improving healthcare quality across the U.S., and we have a special focus on improving care for people with multiple chronic conditions and other types of complexity in the community. As a geriatrician, I am especially pleased with the topics for today's presentation. This webinar is the sixth in a series of webinars that are organized by AHRQ's Share Approach project, which features expert speakers discussing topics related to shared decision-making and the use of patient-centered outcomes research, or PCOR, to facilitate patient engagement in their healthcare decision-making. For those who are interested, recordings of all the past webinars conducted in this series are available at the web address listed here, and these webinars are available for enduring continuing education credit. We're pleased to have with us today two esteemed presenters, Dr. Kathleen Moreau from the Geisel School of Medicine at Dartmouth, and Dr. Mary Reeder of the Puget Sound Healthcare System. Our event is accredited by Professional Education Services Group. It's important to note that neither the presenters nor the sponsors of this event have any financial interest to disclose, and no commercial support was received for development of this learning activity. For those of you who are interested in receiving continuing education credit for participating in this activity, information about how to claim your credit will be presented at the end of the presentations and will also be emailed to you after the webinar. Just a brief note about questions. We have some time at the end of the presentations to address participant questions. However, during the presentations, feel free to submit questions that you have for the presenters using the Q&A panel located on the right of the PowerPoint slides. As a reminder, participants are in a listen-only mode, so to ask questions, you will need to use the Q&A panel. The objectives for today's webinar are for participants at the conclusion of this webinar at the conclusion of this activity, participants will be able to, one, describe the rationale and research behind shared decision-making and its potential for improved outcomes in chronic disease, explain the differences and complementary qualities of motivational interviewing and skills of shared decision-making. Three, outline the clinical applications of shared decision-making principles to chronic disease. Four, distinguish between how shared decision-making is used in medical treatment choices and for other preference-sensitive choices frequently faced by aging veterans, for example, a choice of long-term care services and support. 5, explain the short and long-term outcomes of successful shared decision-making for aging veterans. I'd like to introduce our first presenter today. Dr. Kathleen Moreau is the Department Chair of Community and Family Medicine and an Associate Professor of Community and Family Medicine at the Geisel School of Medicine at Dartmouth. She spent much of her career in the field of primary care, clinical education, and directs the family medicine curriculum in shared decision-making, currently taught to all Geisel students. Clinical and shared decision-making interests intersect in her keen engagement in the practice of shared decision-making across the full spectrum of primary care, and it's important in acute, chronic, and preventive spheres. She received her medical degree from the University of Vermont College of Medicine and completed her family medicine residency training at the University of Rochester.
Arlene, Thank you for attending, everybody, today, and particularly I appreciate the opportunity to talk about this topic, shared decision-making and chronic disease, which I think is particularly important and perhaps a little more complex than some of the more obvious uses of shared decision-making in surgical choice. So I welcome the opportunity to talk about it and look forward to your questions. Just some quick definitions. Shared decision-making has been written a lot about and has lots of different definitions, and I've put together those that we think about when we're teaching basic principles of it to our medical students. Certainly, it's a communication skill focused on patients' values and preferences in the context of medical decision-making. But it's also, I think, really an attitude and a philosophy and approach to thinking about effective patient care, and it really acknowledges the collaborative nature of good medical care and the very important principle that there are always two experts in the room, the physician perhaps being the content expert, but no one knows better than the patient what their values and preferences are. It's really an interpersonal and interdependent process. It recognizes that decisions is required and that information about options and choices is helpful, but often not sufficient by itself. It ideally highlights best medical evidence about risks and benefits of options, balanced by the patient's values and preferences, and obviously is a really dynamic interplay between providers' guidance and the patient's values and preferences. Recently, there's been some really excellent writing about how the conversation involved in shared decision-making in and of itself is an instrument of care, appropriate to the uncertainties of illness and treatment. And in chronic disease care, I think this issue is particularly important because patients' chronic diseases change over time, individual patient response and preferences change over time, and revisiting those issues repeatedly over time as we care for patients with chronic disease is really essential. A little word about categories of care, which I think helps us clarify when and where using a shared decision-making approach is particularly important. We think about the three categories of care that were really early established in the 70s by work by Dr. Wenberg, which gave birth to something that is quite well known here at Dartmouth and nationally known as the Dartmouth Atlas. And that was that observation that there was geographic variation in the kinds of care our patients were getting all around the country, and that often physician preference dominated not only the type of care but the choices offered to patients. So we like to help students understand that effective care is simply care for which there is good evidence base that's well established. You might think of immunizations as a good example of that. Supply-sensitive care is that category that's really guided by that idea of geographic variation. And preference-sensitive care is all that care in between where there are many options and choices, and there is not data or evidence that absolutely prescribes one treatment over another. And all of you, I think it's obvious to all of you that in chronic disease there are multiple preference-sensitive kinds of issues that come up. This just a little graphic illustration of that, and this is a little quiz we give to our medical students to help them think through which type of care these different might represent. But we do also really want to emphasize that there's often overlap between these types of care. They're not absolutely mutually exclusive. As a good example, I will often talk about breastfeeding. Clearly, there's a very good evidence base for breastfeeding as effective care, but anyone who's done breastfeeding counseling or work with patients around breastfeeding understands that you must be sensitive to preference-sensitive matters such as culture and family and sorts of other norms that have a significant impact on a given family's decision to breastfeed or to not breastfeed. Component that I'm just going to touch on today is the use of decision age. I suspect most of this audience has some exposure and has used decision aids. There are a large host of them, but their goal is really to act as a tool that hopefully often in a graphic and clear manner reviews the evidence-based information about options, and they're used as a helpful tool in assisting patients with values clarification. And recently did a big review of decision aids to look at the evidence that they are helpful, and in many ways decision aids have been better studied and reviewed than other aspects of shared decision making in chronic disease. There's really high quality evidence that decision aids compared to usual care improve people's knowledge regarding options and reduce decisional conflict related to feeling uninformed and unclear about personal values. And moderate quality evidence that decision aids compared to usual care stimulate people to take a more active role in decision making and improve accurate risk perceptions, which is obviously quite important in people understanding the risk-benefit ratios. I'm going to jump to the question, motivational interviewing, which is another issue that often comes up in thinking about communication skills related to shared decision making. So motivational interviewing has certainly some overlap, but it's really motivational interviewing we tend to really focus on effective care. That is care that we are really hoping that patients will take up and will there's not so much preference sensitivity, but rather there is excellent evidence this is the right decision to make, and our goal is to help see how we can help facilitate a patient's sense of motivation about taking the steps rather necessary to make changes that are in the classic motivational interviewing is tobacco cessation. Just as a matter of helping understand what's the difference between the two, I have put in here classic kind of distinguishing questions. So in motivational interviewing, you often open the discussion about where are you on a scale of 0 to 10 in your interest in quitting, why isn't the number higher, why isn't the number lower. Where shared decision making, I think, is really, there are a number of options here, and can you help me understand what's important to do about this? What are your particular values and preferences? So there's overlap, but they often have quite different goals, and they're often rooted in different motivations for helping move a patient from where they might be at any given moment in their understanding and willingness to think about behavior change that's so often related to the kind of work we're doing with patients, particularly in chronic diseases. So I'm going to move into thinking through how you go about thinking about decision support inside of a clinical encounter in chronic disease situations, and we'll talk a little bit about the evidence as well. So there are a number of different ways to plan your strategy when you're thinking about shared decision making in chronic disease. Certainly confirming or acknowledging, opening that there is a decision to be made and making it explicit that the patient has a significant role in that decision. Verifying the patient's understanding of options and risks and benefits best with that decision in light of what the values and preferences of a given patient are, and then thinking on to planning next steps. AHRQ has given us a nice, easy to remember way to think about this, and I just reproduce it for you here. So it's really reiterating what I just said, but can be helpful. If you're a mnemonics person, this can be helpful. So seeking their participation, helping explore options, assessing values and preferences, reaching a decision, and then evaluating, planning, follow-up the decision. I want to emphasize that often many of the stepwise approaches to shared decision-making talk about exploring and comparing treatment options first, and then talking about patients' values and preferences. Secondly, my clinical experience is that it's often very helpful for me to start with assessing patients' values and preferences, because so often patients have a clear idea of what's acceptable, important, or important to them, and they can often help you more efficiently recognize that you don't need to talk about every single option with them because they've already made clear, because of their own values, some specific things that they wouldn't even consider. So that's just something to think about when you're thinking about how you're going to approach. If we talk chronic disease management, all of us who are providers understand pretty quickly where the challenges lie. In this slide, I want you to think for a second about how the experience of a diagnosis of a chronic disease is for a patient. Many diseases don't have overt symptoms that immediately impact patients' daily lives. Many patients, therefore, deny or want to minimize the impact of chronic disease on their lives. All of us want to be well, and often our patients with hypertension, with hypercholesterolemia, with diabetes, we often feel well until their diseases are quite progressed. No one likes to take medicine, and the diagnosis of having a disease diagnosis applied to you has important and often for patients negative impacts on patients' sense of self, their own psychological and emotional health and well-being. We get so used to giving people diagnoses day in and day out that we can forget that it can be a really startling and disturbing experience for a patient to think that they are well and then discover they have something that we have labeled as a disease. So I think that's an important sensitivity and way to begin thinking about how shared decision-making can be helpful in helping us think about patient care. Similarly, we providers have our challenges in chronic disease management. We never have enough time with our patients. The process of educating patients about chronic disease is complex and lengthy. Providers vary a lot, as you all know, in skills and interest. to educate, explain, and understand and assess where a given patient is in the developmental process about understanding their diagnosis and acknowledging their diagnosis. Many are fatigued by the work and can feel helpless and hopeless. This comes up a lot in the obesity literature, one of the more challenging places for providers to keep reminding ourselves that this is important work and we have to keep at it in order to see change over time. And this sense of negativity or, geez, it's just not worth it, my patients never change, they're not willing to change, can contribute to sort of a self-fulfilling prophecy. So I think it's very important to acknowledge that it's challenging for both parties to manage chronic diseases effectively over time. Some principles that I think are very helpful. You can't get it all done in one visit. Relationship over time is essential. This is really, I like to think of chronic disease management as a conversation over time. We're not going to solve all of this problem in a single one time, but over time we are going to manage this and we're going to work at this together to make you healthier. Chronic disease lends itself well to management diversity. So we're lucky here where I practice to have access to electronic visits, medicine, and some phone management. As I don't need to tell the audience, current payment modalities often are not very helpful in this regard, and our hope for the future is that ACOs and capitated payments will improve the challenge over time as we move away from fee-for-service individually and look more closely at outcome, and particularly in chronic disease, this will be important. So a few words about evidence base. As I mentioned, there's a quite solid evidence base for the use of decision aids. The evidence base for outcome in chronic disease is much weaker. Most of the evidence base that exists is really focused on, as you can see in this slide, specific elective surgeries, BH surgery, PSA screening, some end-of-life care, and that's just a summary of the most recent systematic review of about 50 studies. There's a much more robust evidence base that patients do not feel well informed, and that with a decision-making approach in the broader sense, patients have a more accurate understanding of their risks and benefits when they're queried about their level of comprehension about their chronic diseases. With a shared decision-making approach, they show better understanding, they show less decisional conflict, and they show better congruence between their values and the treatment. And we all know that shared decision-making now is a CMS quality metric and required for patient-centered medical home recognition. The other big issue with shared decision-making in chronic disease that we shouldn't forget is that of adherence. Everybody is well aware that adherence is an extraordinarily, or rather non-adherence, an extraordinarily expensive profession in this country, and is multifactorial, but there is good evidence that engaged patients who have shared in the decision process feel that their values and preferences have been considered, are much more likely to remain adherent. This slide just summarizes the evidence that suggests which conditions are the most receptive to programs, various programs to improve adherence. And you can see on the left column there that they're virtually all chronic diseases. So in terms of at least the question of the way in which shared decision-making improves adherence, chronic disease is really ripe for that area. A lot of studies show in the adherence realm that we don't do very well. Even in issues such as post-MI, when most of us would assume our patients really have had a significant event with a big impact on their life, and therefore should have great adherence to their statins and their aspirins and their beta blockers and ACE inhibitors, but really the studies that show adherence even post-MI show very low, 40 to 50%, about 1 to 2 years out. And that's true across hypertension. It's true across diabetes. It's quite remarkable how poor multiple studies are in terms of chronic disease in adherence to medications. Statin users as well show over a 10-year period of time that they get heavier and higher caloric intake compared to matched controls who are not statin users. So it's all just underscoring the value of emphasizing that their decision-making approach really might lead us to have more success in attaining the difficult job of remaining on medications chronically and over time. And there's similar data about diabetes here. So I want to just try to wrap up with thinking about how we approach a chronic disease using a shared decision-making approach. So our goals are to nurture an activated patient who acknowledges his or her disease and is about controlling it. Recognizing that patients have their own time frame, personal and family needs, and that we have to recognize that these change over time and keep revisiting these. We are going to be all acknowledging and embracing their autonomy, recognizing that patients who don't make decisions, that is a type of choice, and sometimes that's very helpful to point out to patients. But it's also never about patient abandonment. We do not leave patients feeling that it's completely up to you. It's really a sense of this is a team. We are a team together, and we're going to tackle this together. So I've just put together some questions here that help me think about very chronic diseases and how I might approach them with patients. You have diabetes. Tell me how you understand that. What does it mean to you? If all you do is ask that kind of question about a new diagnosis, you will, and then listen, well, you'll learn an enormous amount, both about where your education focus needs to be, but also about what some of the challenges your given patient might have in changes, particularly some of the behavioral, lifestyle, diet kinds of changes that are really required of anybody who has type 2 adult onset diabetes. What do you think you need to manage this problem well? What's important to you? Who else is involved? This is a very important aspect of chronic disease management. We so often talk to our individual patients and fail to think about who's actually buying the groceries at home, who's doing the cooking at home, who else is involved in either helping you control this disease or hurting your management of it. And a set of questions about hypertension. What does to you? What's important to you? Do you have specific preferences? And who else is going to be involved? Again, same sorts of principles. and lipids, the same this is an illustration of a place where I always use a decision aid, and as I mentioned, decision aids are tools. They should be used when they're helpful. No one should be a slave to them. For me, when I'm talking to a patient about their lipid status, I find the decision aid from the Mayo Clinic extremely helpful, and find that I review as just a stick picture of a decision aid that's very active. And if you're not familiar with many decision aids or haven't used many, the Mayo Clinic decision aids is a great place to start. They have some of the better, most useful and helpful decision aids, and they, in context with that conversation I emphasized earlier, I think really can make an enormous difference. Just going to close with a couple of words about lessons learned. I do want to emphasize that we should never leave a patient feeling abandoned. Sometimes you will work in a very shared decision-making way with a patient who will say to you at the end, "Just tell me what to do, doc." And I am fully comfortable with that role as long as I feel that a patient has understood that there are options, and I feel that I have understood what's important to the patient. That doing nothing is a choice, and sometimes that helps to identify that agency and self-efficacy are essential to controlling chronic disease. That's something I want to underscore. We see a patient a tiny slice out of their lives, and then they go live their whole life. We can't possibly manage their chronic disease. This is really their work with our support, and that shared decision-making really facilitates that kind of understanding if we do it effectively and repeatedly. And I'll just close with decisions in chronic disease are never done. The circumstances change over time and require revisiting those issues frequently. So thank you for your attention, and I'll look forward to your questions.
Thank you, Dr. Moreau. As a reminder, if you have questions for Dr. Moreau, please use the Q&A tools to send them to us, and we will get those questions after our next presentation. It is my pleasure to introduce our second featured presenter, Dr. Sherry Reeder, who will be talking about shared decision-making and long-term care planning. Dr. Sherry Reeder currently serves as Director of Shared Decision-Making for Aging Veterans at the VA. Reeder's PhD is in health communication, and she has a Master's of Science in Public Health, both from the University of Washington. Many years of experience spans a broad range of cross-cultural public health communications topics. For the past decade, Dr. Reeder has devoted her work as a VA research investigator to development, implementation, and assessment of a shared decision-making model designed to facilitate veteran-directed choices about preference-sensitive decisions related to maintaining independence and supporting aging in place. Okay.
Hello, everyone. First of all, I'd like to thank Kathleen for doing such a wonderful job providing an overview of shared decision-making and describing the provider role in such a wonderful way. If all providers did things well as she described, we would just be in fantastic shape. So I just want to thank her so much for such a very useful and positive presentation. I'm going to be focusing on using shared decision-making for aging veterans, and I do work for VA, and so this focuses on veterans, but I think is very applicable to all older people, not just to veterans. So decision-making, And shared decision-making, as Kathleen said, has many different definitions, but we have been focusing on it as it's being collaborative and directed decision-making process that assists veterans in assessing their healthcare needs, setting priorities, and making choices that help to achieve their goals. On aging veterans. We focus on aging veterans or aging people a lot because that older veterans are the fastest growing cohort that we serve at VA. By 2017, almost half of our veterans will be over 65. A lot of those people will need long-term services and supports during the course of their life. About 70 or out of 100 people need those services. And described, this is sort of the conventional use of shared decision-making that I think you're all familiar with, where we provide really good information to people about a particular health condition so that they can make good decisions about screening or treatment related to the particular condition. But should also be used for their preference-sensitive choices that aren't really screening or treatment. That's what we've focused on here. So we've focused on using this for making decisions about long-term services and supports and advanced care planning and things that are very commonly needed by our older population. So we have these decision aids here that are shown that are for veterans, and a separate one that's for a caregiver, and we'll talk about those a little bit more. I will also see the website here. This is the Geriatrics and Extended Care website at VA. And if you haven't ever looked at, I would really like to encourage you to do so. The website has lots of information about long-term services and supports and advanced care planning, but also about shared decision-making. When we talk about shared decision-making, as I said, we're talking about that collaborative process that may be asynchronous. So it may not be everyone together in a team meeting. In fact, it usually isn't, but it does involve the patient and the family or family caregiver, the social worker, and the medical care team. And they're also working towards those patient-directed decisions. And that the goal is to have those decisions be accepted by all. Maybe an agreement among everyone, but those decisions accepted by everyone. What found, this work, as I said, we've been doing for some time, and we found that what veterans, older veterans, needed in general was more information about long-term care options, more information about those home and community-based services that would assist them in remaining independent, to be asked about their life goals and their preferences, and tools that will help them in thinking through their situation and their preferences and choices. The role of the veteran in this process, this is just a little continuum here, starting with a more conventional medical model where the provider was giving their expertise and telling people what they should do, moving towards something that's more patient-centered, where we see that this is about the patient, this is about the older person, but we're still providing all the expertise in the decision-making, to where we're really patient-engaged. So we're really involving the patient, and fully moving towards a place where decisions like the ones we're talking about here can actually be patient-directed decisions. These are kinds of outcome measures that we've been looking at in this process. So we've been looking at access and referrals to home and community-based services, the extent to which we have veteran-directed choices that are actually based on their goals and priorities. We see an increase in veteran and family caregiver satisfaction with the decision process. the completion rate for advanced directives, increase in veterans being able to age in place, and care team acceptance of veteran choices. Whereas some more distal measures that we are looking at would include decreased use of emergency department and urgent care visits and a decrease in the number and the length of inpatient hospital stays. We're looking at shared decision-making as a team effort for kinds of choices. So, we want to make sure that there are many members of the team are all involved in that process. And like I said, we see this as an asynchronous process. So it isn't that everyone's involved at the same time, but they are all involved in the decision-making process. For these decisions, social workers are often very key to facilitating these discussions. So other of us, primary care providers, specialists, nurses, are also quite involved, and expertise of people in those roles is essential. And I think a lot of what Kathleen talked about previously in terms of assuring that a patient and their family really understand the medical care situation, understand the implications of it going forward, is essential to people being able to make good decisions about long-term services and supports. But it's often the social workers who are the key facilitators in these discussions. I mentioned to you earlier about the GEC website, Geriatrics and Extended Care website. And again, here is the URL for it. And this is what you will see when you go there. And as you can see, it covers many areas. It covers different kinds of services, home and community-based services, residential settings and nursing homes. It has a section on advanced care planning, well-being, geriatric programs, meeting services, paying for long-term care, and of course a section on shared decision-making. So it's a wonderful resource guide for our older veterans and often for staff who may be more or less familiar with the range of service and settings available for long-term care, as well as for shared decision-making process itself. Base services are very important because those really support our older veterans in remaining independent. So this is what you see when you click on home and community-based services, and can then go to any of these services as an example of what it looks like if you go to palliative care. And you'd see these same questions: what it is, am I eligible, what services, how do I decide, what do others say, for each of those services. And when you would click on those tabs, you read information about that. So again, this is primarily designed for the older person, so we've tried to keep it as close to the 8th grade reading level as possible. Also, our videos, most of the services, so you can click on the videos and actually just watch a short video about that particular service. You can also go directly to shared decision-making. So once again, these are things that are very valuable to the older person and their family. Most of this would be very applicable to people whether or not they're part of VA. And it also is a great resource guide for our staff who may be less familiar with these things. Decision aid worksheets that we have, and these are, as Kathleen again talked about, decision aids. These are decision aids, but these decision aids that are really for the veteran and the caregiver. They ask them questions about their goals and priorities, of what's most important to them, and also about what resources they have available and what they'd like to see happen. So it helps them to think things through for themselves. And we find that that really facilitates the discussions that they have with their care team and with their social worker if they've thought that through. In some cases, they may actually fill these out. In some cases, they just look them over, but they're very useful in actual shared decision-making discussions. Also, A lot of older people do not use online, do not use the web, do not use online resources. And we have all of these things in hard copy as well. So the summary of the long-term services and supports and information about well-being and advanced care planning, as well as those decision aids, and have all of that in a folder for people so that they can actually utilize that hard copy version if they don't, if they're not comfortable using the online resources. Planning is also an important part of this whole process, because most people who need long-term services and supports probably should also be thinking about advanced care planning. So we've included that in the GEC website and also in the hard copy materials. And it's very similar sort of, and it looks the same on the website, what you have when you go to advanced care planning, and you can click on those tabs across the top to find out what advanced care planning is, what's an advanced directive, get some help in completing those advanced directives, and look into other forms of advanced care planning. So once again, that is all available. There is a values worksheet, which is another decision aid, and this is all available both online and in hard copy. You would be using this in a clinic situation. You want to start a discussion sometimes with long-term services and support, sometimes with advanced care planning. The order doesn't matter. In both cases, we're talking to people about what their goals and priorities are to start the discussion. The decision-making process for aging veterans has a number of different components in terms of actually implementing it in a given clinic or service line. We have both orientation and training for everyone on a given team. So if it's a medical home team, it would be all the providers, physicians, nurses, administration, management, social work, everyone would participate, and the orientation, and then there would be a training. We'll talk a little bit more about that in a minute. We also know that there needs to be some policy and program changes. We work on those levels as well to address gaps in availability and access to services and funding issues, and making sure that we're both using the services with ADA, but also understanding that we need to be working with the larger community and very much working with them through community partnership organizations and knowing what's available and making sure that we're using the comprehensive range of what can be used to help our aging population. And then talked about, we also have tools and information both online and in hard copy. But we know that that information in and of itself unfortunately is not enough to change behavior, so we need to do a lot more than just be providing good information to people. Briefly go over what we do with these implementation steps for the orientation and training, because I think it's very important. We make sure that we do a brief orientation with the leadership of a medical center to start with. It's important that those folks know this is going on, be familiar with it, be supportive of it. Our assessments demonstrate over and over again that that kind of higher level support is really important for things being implemented and continuing implementation over time. As I said, we have a training that is about 45 minutes. That's for the whole clinic or service line, where we go over an overview of shared decision-making and how it's implemented and what different members of the team's roles can be in that process and how they can work together in that asynchronous, collaborative way to ensure that we are providing veteran-directed care. And then have a more case scenario-based skilled practice for usually for our social workers. As I said, they're usually the ones who facilitate most of the discussions with the veteran and their family. However, in some cases, everyone on a team wants to participate, or it's particularly a geriatric clinic where the providers have a lot of time with the patients, and they want to make sure that they're involved and they're doing all this skills practice as well. So we leave it up to them to decide how many people and which people they want to have involved in those skills practice sessions. And as we've talked about, the implementation of this also relies on our website and our hard copy materials and our decision-making interviews, which are all our decision-making tools, which are all used to facilitate our discussion. And we're working on our assessment, which includes interviews with staff and veterans and family caregivers so that we can go through our quality improvement process and summarize our findings back with our sites and see what changes need to be made to continually make this a better process for them and allow it to really be well integrated into their workflow, because if it's integrated into their workflow, it won't work for very long. An idea of the places where we have been implementing this shared decision-making for aging veterans. So you can see there are many sites across the country, and this has been supported within VA primarily by geriatrics and extended care, but the Office of Rural Health has also been very involved with this project, as has the Office of Patient-Centered Care and Cultural Transformation. And we work very closely with care management and social work services in the development of our orientations and training as well as implementation. So just these are some of the key concepts of shared decision-making for aging veterans. We want to ensure that there has veteran self-identification of their goals and priorities on their values and preferences and needs. We want to ensure there's the involvement of the care team in that collaborative and often asynchronous discussions with the veteran and with their family. That understands their medical conditions and the likely effects of those on health and function and options for obtaining services and support. That we provide comprehensive information and the use of decision aids to our veterans, to all our older people, so that they can make good veteran-directed choices and have access to home and community-based services that support aging in place. Through all this is the veteran is at the serve, but of course all of us on the team play a very important role in making this all possible. We're looking forward to your questions and hopefully in the future to working with you all on implementing these kinds of shared decision-making processes. Thank you.
Thank you, Dr. Reeder, and thank you to both of our presenters who did a wonderful job today. But concludes the presentations. We will now use the remaining time to address any questions from the audience. But before we do that, please take a moment to jot down the link on this slide if you're interested in receiving continuing education credits for this activity. However, note that this information will also be emailed to all participants following the webinar, so you will have the link. Let's move to questions. As you were instructed earlier, please use the Q&A panel to send us your questions. Please direct the questions to all panelists so that we can address them. We've always already have some really excellent questions. The first question is for Kathleen. Kathleen, can you talk a little bit about when you would use motivational interviewing as opposed to when you use shared decision making?
Sure. It's a great question, and I think it's often for who have recently had training in one or the other, it can be confusing. I often describe that motivational interviewing and shared decision making are two different communication skills, and we often dance between those two communication skills depending on the clinical circumstances that are in front of you. So again, I'll use the easiest one for motivational interviewing. When you have a clinical content where there are not a lot of treatment options and choices that a patient needs to consider, rather that the evidence is so strong for a single choice that my goal as a provider is to work with this patient to help them take up that one piece of advice that is so critically important. So the classic motivational interviewing topic is quitting tobacco. And the evidence is overwhelming. Of course, patients have choice. They can choose not to quit, and they can choose various approaches. But my goal, because the evidence is so clear, is to help see what is it going to take to motivate this patient? Where are they along the trajectory of stages of change? And what can I do to help them move that number on a scale of 0 to 10 about how motivated are you to quit? What approaches might I think through with the patient to get them to move? Say, my interest in quitting is at a 4. Well, why isn't it a 5, and why isn't it a 3? So I think that's a specific skill for clinical topics where there are not a lot of choices and options, and it's very clear that the evidence is overwhelming that we would like the patient to make a given choice that we're trying to help motivate them toward. In shared decision making, we're using communication to explore options and to understand their values and preferences in such a way that we might be able to help them in the decision process about what is the best choice for me. For example, some clinical examples might be helpful. For colon cancer screening, if I'm trying to figure out how I'm going to get the patient to either decide whether they want to use a FIT card testing annually versus going ahead and getting a colonoscopy. Multiple, and some other options too, multiple options depends on multiple values and preferences, insurance, resources, time from work, all those kinds of issues. So it's really the clinical content that helps me decide, do I need my motivational interviewing hat on, or do I need my shared decision-making hat on?
Thank you. Question. When you do decide to use shared decision-making, and Sherry, you might want to comment on this one, how do you decide what modality do you use, paper versus a conversation versus an electronic? And is there evidence on the effectiveness of different, types of shared decision-making approaches and tools?
Right. And this is an excellent question because, as you all can imagine, patients differ widely in their uptake of decision aids and the modality you use. So, as Sherry mentioned, in many elderly geriatric patients, using electronic tools is simply not helpful, and the conversation itself is is most important. In younger people who live on the web and who dash between one and the other, using electronic tools can be extremely helpful. They are used to watching videos. Their uptake of those kinds of tools will often be much higher. I will emphasize over and over that I don't think anything replaces a conversation. I do think particularly when there is a medical decision that needs to be made, the conversation's an essential component. But well-educated, well-informed patients who have used some decision aids ahead of time, who reviewed a video, who have looked at a fact sheet about the content, those kinds of tools make your work in the conversation part much more efficient, because they tend to come pre-educated with some questions already in place, and you are not having to start the conversation at the very beginning. So it's so patient dependent, and your relationship over time with your patient, knowing them well, can often make a big difference in that. I want to emphasize, Sherry did it well, and I should have emphasized more, this is a team sport. Physicians, providers can't do this all. In my facility, I have the benefit of having both access to health coaches as well as care managers, and so often a lot of the pre-work might be done with a health coach, with care manager, with our MAs or other nursing support services, so that the conversation has already been primed by some earlier education. Diabetes educators, nutritionists, there are all kinds of people in chronic disease management who are a critical component of helping you have an efficient shared decision-making conversation when the time comes.
Everything Kathleen has said, I think that the provider can also really encourage older people, all patients, but particularly older people who tend to really rely on their physicians a lot for expertise. So those physicians can encourage them to use resources and information, to use decision aids, to think things through on their own a bit, and that very much helps prepare them for the conversations, which I think work there for them and for the healthcare team. I also think in terms of technology, as people, as baby boomers age, they'll be using technology more than the current older population. So you're seeing a continual increase in the extent to which technology is used. And I agree that the conversation is the most important piece. We actually tried having conversations over using technology, so to see people on screen and have those discussions. And basically, that works well, except that there are so frequently technology glitches. And those technology glitches are really major setbacks and frustrating for everyone. So I think that as the technology improves and is simpler and people are more comfortable with it, that will become more and more an additional way to have those conversations, particularly with people who live at a distance in more rural areas, or who have chronic conditions that make coming to the clinic a burden and difficult. And if those conversations can be had over chat on the computer and they can actually see the person they're talking with, that is and will become ever more a very wonderful option for a way to have some of those conversations with our older population.
So a quick question for Sherry. Are tools from the VA available with audio for visually impaired vets?
Available with audio at this time. The tools are not. I wish that they were, but they are not. The tools themselves are available. They can be downloaded from the website, so they're easily available to people in that way, but not available with audio.
And another question here is, somebody wanted you to expand more on the amount of time it really takes. You said it really It's only a few minutes to the visit, but there's a lot of skepticism about that. So a little bit on the pragmatics of how much time it really takes, and also some of the logistics of scheduling and fitting it in when you have multiple demands in a visit.
Yes, very good questions, and I noted a number of them about that. And the skeptics are of course right to be skeptical, because particularly when if you're developing your skills in shared decision-making conversations, I think they can take more time. I emphasized at the beginning of my presentation, and I'll say it again, why I talk about the importance of an attitude and philosophy. So in my practice, and I feel like I am using a shared decision-making approach all the time. That is, I don't book formal shared decision-making conversations, but when the clinical circumstances dictate, the shared decision-making approach, saying, help me understand what's important to you about learning that you have high blood pressure, for an example. Those kinds of ways of wording the question and genuinely being interested in the patient's approach to that, over time you'll find becomes you replace some of the ways previously you might have interacted. So instead of just example, listing all the different drugs that you might take for hypertension and the risks and benefits or the side effects of each of them, I will start the conversation by saying, help me understand what this diagnosis means to you. What do you know about high blood pressure? What to me, and just that, even if that's all I do in a given visit, I have learned a lot about what kinds of treatment choices and options I might need to talk to a patient about, and also I've learned a lot about some barriers that they may have. And depending on where we are, I might give the patient some information to take home to read about. I might work on a particular area of, say, for diet or exercise, those kind of things. I might bring in a health coach, recommend a nutritionist for someone who's overweight. There might be a range of pathways we take, but I never formally schedule something that's called a shared decision-making visit, and I don't, in my view, it's part of the way we simply approach patient care, and we meld it into our regular day-to-day care. It's been very hard to study. The studies that are out there, there are some that claim it only, quote unquote, only takes a few minutes more. There are some other studies that show over time that a well-informed, educated patient who understands their option actually takes less time. So that's a very tough thing to measure, but I don't want to pretend for anybody that there's a quick fix here. This is about conversation. We have them all day. It's really with our goal being better outcomes and their adherence and patients understanding their disorders, their diseases better, because we know that leads to better long-term outcomes.
And I would agree that, unfortunately, the research on this is not good. But in the interviews that we've done with staff over time at some of our implementation sites, we have found that some of the staff definitely gives feedback that it does save time in a certain way for them. You have to explain what respite care is 4 times, because they actually showed someone on the website, they actually gave them the summary of services and supports, and that person has that information, and the family support person or family caregiver has been involved, and so that person really knows that information now from the comprehensive information that is direct towards them and well done, and everyone makes sure they have it. So I think there is some savings there over time. I also think it's a very interesting question about whether the extent to which this can just be incorporated into what we already do in our clinic situations, and the extent to which having a, quote, shared decision-making appointment is something that facilitates the process going forward. And at one of our sites, actually in Houston, they are beginning a process where they are actually having shared decision-making visit for patients that are identified in terms of chronic illnesses, being over 65, being some of their sicker patients. And they are scheduling one shared decision-making appointment, which is a longer appointment, and not necessarily an appointment that is only for the provider, but rather a block of time that is then devoted to this initial process of discussing goals, priorities, et cetera. And it may be that the physician has most of that time or a piece of that time, and most of that time is with the social worker or with the nurse or with a mix of people. But it's all centered around people who have been trained in this process, are committed to it, and are working together with the veteran to have these discussions. So I think some good assessment of that as compared to just integrating it into the regular flow of visits is something that will prove very valuable over time.
A question, actually two follow-up questions that are very different. The first one is, can you talk a little bit about the role of other team members with respect to shared decision-making? Somebody specifically asked about the medical assistant, but any other, members of the team and their role, and also communication across the team in terms of a patient's decisions.
Go ahead, Sherry.
Kathleen, that's fine.
Other team members and the medical assistants, let me tackle that. I've mentioned specifically health coaches and our care managers in my medical center. Health coaches and the care managers are all trained in a shared decision-making approach. And so that can be very helpful. A diagnosis, say, of diabetes, I will be very quick to offer the services of a health coach, and a great deal of the early work is done by the coach, and then in my regularly scheduled follow-up, I'll be in a better position to be able to tackle the more medical challenges or the medical kinds of questions where the health coach, the diabetes educator, the nutritionist, any of those kinds of resource people will have gone a long way towards helping. I'd also mention that we teach the Stanford chronic disease group classes, so I also have the resources of referring my patients to the Stanford group on diabetes and the Stanford group on obesity and overweight. So and as most of you know, not every patient will take you up on going to a group, but we've found that to be a very positive addition, and those are run by our health coaches who, again, have this kind of shared decision-making approach and help the patients often think through, well, what really are the kinds of questions and specific concerns I have that I'm going to want to bring back to the patients. Medical assistants, we've been experimenting a little bit with trying to give them some core skills. They do some rooming of the patients, some taking history, medical and family and social history changes, updating that part of the chart. And so simply exposing them to asking them, giving some language about preferences and values, and if that fits into their conversation, sometimes the medical assistants will have a conversation with the patient that's actually very useful. In terms of communicating across the team, I just want to emphasize that most of us will share some shared decision-making templates in our notes that will document that used. An example would be use shared decision-making approach to discuss contraceptive options, patient shows, lipids, these kinds of things. So we're careful to document it in our notes, and I think that's the best way we have for communicating across team to fellow providers. If directly working with the diabetes educators or the health coaches, then we'll be doing direct referrals to them, and so we'll have a conversation, at least electronically, about here is patient X that I'm sending to you, and here's my goals. Can you help me work on this aspect of this new diagnosis, or type 2 barriers. I don't understand barriers. Can you help get at them? Those kinds of things.
And shared decision-making for aging veterans, as I think I went over in the PowerPoint, that initial orientation for the whole team or service line is talking about the roles in shared decision-making for all of the team members is a critical piece of that. So again, what we have found in our assessments is that initial orientation is very, very important. So everybody on the team has a shared understanding of shared decision-making, knows what that process is, how we fit, and then we have some actual practice during that orientation with the team, so they can talk about what their roles might be. Because what we have found to date is there really is significant variation in what the roles are, depending on what we're talking about. If we're talking about a rural outpatient clinic, most of the VA medical centers have community-based outpatient clinics, and a lot of those serve very rural populations, and they're very small and they have a very small staff. They may handle things one way in that primary care setting. In a medical center, a large medical center, they may handle it differently. In a geriatric clinic, as I said, where the physicians have 45-minute appointments with the patients already, the physician themselves may see themselves as the primary person to talk with the veteran and their family about their goals and priorities and choices. And we have home-based primary care where people stay home who it's too difficult for them to come to the clinic, and the team comes to them in their home, and they may handle it again differently. We have found that the social workers, as I've said, are very primary in facilitating a lot of the discussions. Nurses may be people who introduce this initially and make sure that the patient actually gets the package of materials and is familiar with it. They may also, in some cases, do some discussion of the health care conditions of that person and how they may impact their choices. In some cases, it's the administrative person who welcomes people to the desk, who, when they first come into the clinic, that may make sure they get this packet of things. So there's considerable variation across service lines and clinics on who takes which roles, and it's very important that that whole clinic then talks about that and that there's general agreement on how they are handling that and how they would like to do that going forward. So that's very important. I think the part about documentation is also a very key point. Often that is one of the issues that physicians may make notes, but their notes may not be read by others on the team, or likewise, the notes of a social worker or a nurse may not be read by others on the team. One of the ways we've been trying to address that now is through a parent-child note on shared decision-making, which means that multiple people in differing professions can all and should all be making notes related to the shared decision-making process for that patient on the same note, so that it's very easy for everyone to read what's gone on in that process and where they are. So that seems like the best mechanism for that to date.
Actually, there's quite a number. We're running towards the end of our time, and there's actually a lot of specific questions for Dr. Reeder, specifically about the VA, and I would like to get some of those in before we finish. So one of the questions is there a rollout time of shared decision-making across all VA facilities? Somebody else was wondering about rolling it out specifically in the South, in the stroke belt. And then there was a question about what to do when the vet lives in one state and family and caregivers are living, scattered at great distances.
So those are some different kinds of questions in terms of rollout within the VA. So this probably, the VA is a centralized organization, but it's sort of like federal government versus states' rights. And so although it's a centralized organization, there also is great diversity among the differing VAs across the country. I work with central office a lot, and as I said, the geriatrics and extended care office and social work, and there is very strong support by all of those groups for implementation of shared decision-making for aging veterans across VA, and being implemented very much on a, I would say, medical center by medical center and program by program. So some programs, like I mentioned, home-based primary care, we have more of a plan within home-based primary care for making sure that all the home-based primary care programs receive the shared decision-making training and are aware of the program and implement it. But the choice about implementation within VA is very much on a medical center by medical center basis. So in terms of comprehensive rollout, I would love it if that were the case, but that isn't really how VA operates. So we have continued its spread by working specifically with geriatrics and extended care, social work, and the Office of Rural Health, and other offices that are in strong support of using this process and have great reach across the country. So that's really the most I can say about that. If anyone is specifically interested in any particular program or service line and how we may be implementing it or adapting it for that particular program or service line, please don't hesitate to get in touch with me. I would be very pleased to talk with you about that. And I want to make sure that I mention, yes, it's very common for older people and for older veterans to be more isolated and have families in other locations. We make a great effort to contact those people. That's part of the shared decision-making process. That has been a priority at VA for some time, to make sure that family caregivers are really involved in the process, and I would say during the past decade that has only increased in importance. So there's been a strong effort to contact those people, and also this has to do with telling people about the comprehensive range of services. Most older people, as I'm sure you all know, will say that what they want to do is stay in their home. They don't want to move. However, it's really important to give people comprehensive information about availability of services, to talk to them about where their family lives or where other people who are very close to them live, and to really encourage them to explore those options. Sometimes people surprise us and they suddenly say, oh, well, my nephew Jeff, who lives in San Francisco, has been asking me to come live there for years, and all those services are available right there, and there would be easy access for me. Well, maybe this is the time for me to do that. And people make choices. I think as professionals, we often think that we really know people and we know what their choice will be based on past information, and I think that that's one of the things about shared decision-making and directed choices that we need to be very careful about. It's lots of patience, and even with our best friends and our spouses, I think we all know that it's very difficult to know what choices people will really make when they're given a comprehensive range of information. And so one of the basic premises of shared decision-making aging veterans is to make sure that they have that comprehensive information, that their family caregivers have that comprehensive information, that they have tools for thinking about what choices they want to make. And sometimes they make decisions that surprise us. And sometimes we think those were choices, and sometimes we don't think that they're good choices. But it's our job to make sure that they have the information and skills to do the best job they can to make choices that meet their goals and priorities.
Thank you. So we've gotten so many wonderful questions. I wish we could ask them all, but we've run out of time. There were questions about the strength of the evidence, and I know that Kathleen had cited a Cochrane review on the topic. Also, lots of interest on what is the strength of evidence for different ways of implementing shared decision-making. So there's a lot to keep talking about, but unfortunately, we've come to the end of our time for this webinar. And if you have questions about AHRQ Share Approach resources, you could send them to Elena Fournier at either of the email addresses listed on this slide.
Arlene, I'm happy also to have folks email me directly there were a lot of good specific questions that I'd be happy to tackle with people individually. So if you had questions, and please feel free to use my kathleen.morrow@dartmouth.edu email.
Thank you. And just as a reminder, use the following web address to claim your continuing education credit. And once again, I can't thank the presenters enough for their great presentations, and thank you all for participating, for joining us, and also for all the wonderful questions that were asked. So this concludes the webinar.